All right. I'll give people a few minutes to join and get settled, but welcome. All right.
We can give everyone another maybe 30 seconds and we can get started.
Okay, that sounds great. Yeah, I thought I could see the numbers, but I can't right now.
All right, welcome everyone to the 2021 Virtual SMA Conference. This is Colleen McCarthy O'Toole from Cure SMA's Family Support Department, and thank you all so much for joining us today for pre-symptomatic physical therapy consideration session. We're so grateful to our national presenting sponsors, Biogen, Genentech, and Novartis Gene Therapies for their incredible support of this year's virtual SMA conference. Please note that all lines will remain muted during this session. If you have any questions, please find the chat conversation tab located on your screen and you can submit questions through that. We would now like to introduce Leslie Nelson with UT Southwestern and Dr. Stratton with Children's Hospital Colorado.
Hello, welcome. I'm Ann Stratton. I'm one of the PEDS rehab docs in the neuromuscular clinic at Children's Hospital Colorado. And this is my colleague.
Hi, I'm Leslie. Yeah, sorry, Ann. I'm Leslie Nelson. I'm a physical therapist. I work in Dallas at UT Southwestern, and then I also see patients at Children's Health in Dallas as well.
All right, excellent. And so we want to welcome you, and we're going to talk today about pre-symptomatic physical therapy considerations in the SMA population. There we go. Thank you, of course, to our 2021 presenting sponsors. And here are our disclosures. I haven't been very active in any consulting lately in the past couple years, so. All right, so I wanted to jump off our talk talking about newborn screening, because next to disease-modifying therapy, this really is the most impactful advancement for the care of our kids with SMA. It has allowed for us to offer disease-modifying treatment much earlier, typically in that pre-symptomatic period for most of our patients that are identified. And of course, as that evidence has shown, early diagnosis and treatment leads to better outcomes. So SMA was added to the Federal Recommended Uniform Screening Panel, or the RUSP, for newborn screening in 2018 in the United States. Now, this is just a recommendation. It is not a mandate. So it is up to each state to figure out how to best implement this recommendation in their state screen. So if you're curious whether your state offers a newborn screening for SMA, here is a quick map. So about 37 states currently offer SMA screening in their newborn panel. So having worked closely with my colleague Melissa Gibbons, who was really our champion here in Colorado for implementing SMA screening in our state's newborn panel, it's a complex process. So if your state is not currently offering it, have some patience with them. There is a lot to coordinate. There's making sure that your lab has the infrastructure, the equipment, the reagents, and then really the workflow once the patient has been identified to make appropriate referrals for that patient. So there's a lot of moving parts for that. So have patience, but feel free to bug your local institutions to help move this along, because I do think it's very important. But I have faith that eventually all 50 states will offer this in their newborn screening. So important considerations for this advancement is that even with early diagnosis and treatment with disease modifying therapies, it's still very important to follow standards of care guidelines with a multidisciplinary medical team. So, and it's also important to recognize that newborn screening is not 100% accurate. And if you have a negative newborn screen, that does not completely rule out that your child will have SMA. So this does, if you picture the newborn screening as kind of like a wide-toothed comb, it catches about 90% of the diagnosis of SMA. But there's a specific type of mutation called a compound heterozygote. You don't need to remember that, but where there's really a point mutation within the SMN1 gene, rendering it ineffective, and it doesn't work. And so you may still have that SMN1 gene, which the newborn screening catches and sees that, oh, you've got an SM1 gene, you're fine. So you would get a negative result, but that SMN1 gene doesn't work. So it catches all the patients where there is not an SMN1 gene, where there has been a deletion, but it does not count the 10% of patients that have that those point mutations. So keep that in mind. Also, these disease modifying treatments they're not curative yet. We still need to continue to monitor our individuals for symptoms of SMA. It's amazing technology. It has absolutely changed the trajectory and treatment for our patients, and change their lives. It's incredible, but we haven't yet been able to perfectly match the physiologic wild type yet. So meaning, it's not perfect, and we've got to gather more data if we have hopes to get there. The other consideration is that individuals with 4 or more copies of that backup gene, that SMN2 gene, may require some extra consideration. The treatment guidelines for that population isn't clear. So patients with 4 or more copies of SMN2 are predicted to be historically an SMA type 3 or 4, which would be a patient with a higher level of functional capacity. And the timing for treatment and the like still isn't perfectly clear in that patient population. So we're still learning. So what we do know is we have about 5 years of data now with nusinersen. So that's, of course, the original antisense oligonucleotide treatment delivered through lumbar puncture that was approved back in December of 2016 now. And then we also have about 5 years of data from the gene replacement therapy, the anasemnogene apaparvovec, or Zolgensma. And we have about 1 year of data now with risdiplam, which is the oral antisense oligonucleotide. So, and we don't know longer term effects. 5 years, yes, it seems like maybe a long time now, but really it's just a drop in the bucket as far as outcomes into adulthood for our infants. And we need to continue to monitor in long-term extension studies. So Nurture is the clinical trial that was initiated for nusinersen in the pre-symptomatic stage of spinal muscular atrophy. And there's a lot of really encouraging positive data. So compared to those wonderful, rigorous natural history studies that really set the groundwork for all of this, for all of these advancements, after about 4.8 years of continuous treatment with nusinersen, 100% of these patients treated pre-symptomatically survived, and none required permanent ventilation, which is incredible. And patients continue to maintain and make progressive gains in motor function, certainly compared to the natural history disease. And 96% are able to walk, at least with assistance. So that's incredible, because we would not expect that for the majority of these patients in the natural history study. The Nurture study, fortunately, was recently extended to continue to evaluate longer-term efficacy and the safety of nusinersen for up to 8 years of age. And I hope and would advocate that we continue to monitor longer, because I certainly want to know how all of our patients are going to look as adults. The next the next study is the SPRINT study, and that's the study done with the gene replacement therapy, onasemnogene apaparvovec, in these pre-symptomatic patients. And again, great outcomes, 100% survival without ventilatory or feeding tube support at 8 to 18 months post-treatment. And this is at the last visit that was done. 11 out of 14 patients sat without support, and 10 out of 11 patients did this within a normal developmental window. So a normal developmental window for sitting, for those of you who aren't familiar, is really anywhere between 4.5 to 5 months of age up to 9 months of age. And so that's fantastic. And all of these patients achieved a CHOP INTEND score of greater than 50. And what that means, CHOP INTEND, we'll get into a little bit later. It's one of our outcome measures that we follow in our patients. So Rainbow Fish is the last study, and this is the study with risdiplam in patients with pre-symptomatic spinal muscular atrophy. And I have heard positive things, but I'm not allowed to disclose. They're actually going to report on that data at this conference. So stay tuned. So what should we expect? Our infants that are identified early and treated early tend to do very well, and they achieve developmental milestones that we never would have expected in the natural history. So this is very exciting and encouraging, but there is a developmental delay possible. And specifically, we look for symptoms potentially of decreased endurance and some weakness that may be present. Again, this is not curative treatment. We aren't perfectly matching that physiologic delivery of the protein, but it's still amazing, and it's still a huge leap forward from where we have been. But I can't overstate this enough, that we need long-term follow-up and ongoing monitoring. So I'm going to transition now over to Leslie, who's going to talk about what that means and how to work with your physical therapist.
Thanks, Anne. So yeah, I second the thought of the fact that how exciting is it that we do get to talk about how well patients with SMA that have been treated pre-symptomatically possibly can do. But what I do think is it has been challenging as a physical therapist and just in the community in general as to what do. We've been so used to all of the natural history, and we've guided our treatments and our concepts of rehab based upon that natural history. And now we're in new waters that none of us have swam in before. And so we're all kind of swimming together. And that's something that I think that all of you should be really confident in and excited about, is that there are such great teams out there that really are working together to figure out how do we help these patients and manage these patients to get best outcomes. And as Anne mentioned, really, even if you are treated pre-symptomatically, that standard of care and that monitoring over time really is important in the fact that we do need to continue to help monitor and make sure that we are getting best outcomes. And so the standard of care guidelines for physical therapy have been published in an article that Dr. Mercuri and a group published in 2018. And so we have those guidelines that really give us an understanding of exercise guidelines and stretching and bracing types of guidelines. Obviously, though, we have guidelines based upon the population as a whole, but you as an individual or your child as an individual may need to be monitored in different ways or treated in different ways depending on what impairments are present. And so it may be that your child may need braces or AFOs, for instance, for standing, or even for monitoring and maintaining range of motion at the ankle joint. So there are things that a PT, based upon those guidelines, should help monitor to make sure that we're keeping all function and all range of motion and everything at an optimal level. The monitoring of that motor function is really something that we're going to talk about in a minute with how do we do that and what kinds of outcome measures should you expect to be done to follow your child and to make sure that we are, again, meeting their needs based upon if there are impairments and things that we might need to intervene on. One of the things I'd like to really leave with you, though, is that though we have some rehab and exercise guidelines, that really shouldn't be a static prescription. And that's the same for unaffected individuals that don't have SMA. Really, when we talk about exercise, the exercise and rehab should be adjusted based upon response to exercise or stretching or different things that you're doing. And so as you continue to improve or as things change, then you adjust that exercise based upon those changes that are occurring. And that may be that, again, kind of lends to why we do need to monitor over time. And so staying active within your multidisciplinary team where there is a physical therapist or an occupational therapist that can see you on a regular basis and help with altering that prescription for exercise can be very beneficial and is highly recommended. Next slide. So I mentioned the functional outcomes and how do we monitor, how do we look at change over time? And again, we're in a really great, we have kind of this great dilemma, and that we're trying to figure out what do we use to follow change over time. So historically, the CHOP INTEND has been used in infant onset SMA to assess motor function in basically the weaker infants or patients with SMA and the non-sitters, basically. So the CHOP INTEND was developed at CHOP in Philadelphia specifically for weak infants with neuromuscular diseases. And it looks at things like head control in supported sitting and facilitated rolling. And then just movement against gravity. Basically, can you raise your arm against gravity? Can you raise your leg against gravity? And so if you think about a symptomatic child or infant with SMA, some of that movement against gravity doesn't occur. In a baby that's pre-symptomatic, a lot of that kind of movement against gravity occurs, and what we tend to see usually is there may be still some weakness maybe in the neck muscles. So when you go to pull a child to sit, maybe they don't lift their head off of the table quite so easily. So the CHOP INTEND, even in infants that are pre-symptomatic, may pick up some different weaknesses that may be beneficial, and we would use that to follow over time. Anne mentioned in one of the studies that the infants that were in that study, I believe all scored over a 50 on the CHOP INTEND. And what we know from natural history is that symptomatic infants of non-sitter type 1 infants typically wouldn't score above a 40. And so we know that we can see there's a little bit of sensitivity in that, in the respect that we can pick up change in the CHOP INTEND. The other outcome measure listed on this this slide that was specifically developed for patients with SMA is the Hammersmith expanded, the Hammersmith functional motor scale expanded. That's the last one on the slide there. And that one is used for sitters and walkers. So a little bit of a stronger kind of cohort. And what you may see in your child that has been treated pre-symptomatically is that you may have the chop and tend performed for the first few months up to a year of life. And then as your child gains those milestones as far as sitting and being able to roll more independently and maybe kneeling and maybe crawling, that's when they would transition into having the Hammersmith expanded be assessed. But what we also have found is that, oh, sorry, I'm going to have you stay there, Anne, for just a second. What we've also found is that those 4 in the middle are outcomes that were not developed specifically for SMA, but that some of the physical therapists within the SMA community have really started to use. And these outcomes there in the middle are more to assess developmental milestone attainment. And so we're using these to really, with the anticipation that a child treated in pre-symptomatically is going to follow more of that developmental milestone trajectory. And so we want to compare them to norms from a standpoint of being able to see where they fit on that scale. So the TEMP is something that might be used in your clinic. The TEMP is the test of infant motor performance, and it is developed for infants that are 0 to 4 months. So it's going to capture some of those earlier developmental milestones that you may see in an earlier age infant. And actually, an interesting point is that some of the items off of the chop and tend were taken from the TEMP-C, which is a screening tool that's used in line with the TEMP. The next one there, the AIMS, is the Alberta Infant Motor Scale, and it is a gross motor measure that can be used in children 0 to 18 months. So again, it follows a little bit longer, but then again, just captures that kind of normal development. And then the Bailey and Peabody are also norm referenced outcome measures in that they basically kind of tell us where we should fit on that kind of normal development scale. The Bailey covers 1 to 42-month-olds, and then the Peabody actually goes all the way up to 5 years of age. So you can follow a little bit longer on the Peabody. So I just offer those in that what I would expect from an outcome measure when you're seen in clinic is that you're most likely going to get an SMA specific outcome assessment done, like the chop and tend or the Hammersmith. But you may also have things like the TEMP or the Bailey or the Peabody done as well to help follow over time. Okay, now next one. So this is a great slide that Anne had and shared, and my friend and colleague, I think Terry Carey, who's an awesome therapist in Colorado. I wish I could be like her when I grow up, kind of therapist, but she put this together, I think, for a talk, and it's just a really nice kind of overview of the main 3 that have kind of been used in clinical trials, which is the Bailey, the chop and tend, and the Hammersmith. And so again, the Bailey, assesses the 1 to 42 month age kind of developmental milestones. But the nice thing about the Bailey is there's also scales that look at fine motor, cognition, and language that can be used as well. And so those might be something that could be very informative for us to kind of follow your child over time. And again, they have been used in the clinical trials. And then I mentioned again the chop and tend. I didn't mention that the maximum score is a 64 when I kind of talked about that 50 and that 40. And it's not uncommon, even in a very strong infant or child with SMA that even has been treated from a pre-symptomatic standpoint, to have, to not score 64, because there are some things like head lag that are sometimes difficult. And then the other thing that happens is sometimes they just don't like different items. They grow out of items because they're too strong and too old. And so sometimes you may not get a full score, but I give you hopefully the hope to know that don't let that scare you or make you feel like your child's not doing well if they're not getting that maximum score, because it's not going to capture true function in every infant. And then the Hammersmith Expanded I mentioned is our outcome measure that's used in our sitters and walkers. And it looks at, again, it can be used in children as young as 2 years of age, and then all the way up into adulthood to kind of look at things all the way from sitting and rolling and crawling to walking and climbing stairs. So those are kind of again, just an outcome measure overview for those of you that aren't familiar with those. Okay. And then I think last we wanted to touch on kind of what do we do as far as physical therapy itself, and what are the exercise and activity recommendations. And this is kind of a catch-all. This is broad, but what I would say is that really, a child is a child, an infant is an infant, and play is the best thing that you can do. And play in things it will give you the opportunity to incorporate strengthening and flexibility and endurance training. And it may be that, for instance, maybe your child always wants to roll to the right and never to the left. Well, put the toys on the left so that they'll roll to the left, and you kind of incorporate strengthening in those kinds of ways. Flexibility, stretching, those kinds of things can be done in the pool or can be done in the bathtub when you're playing, different ways to kind of incorporate that into your day as well. And then, endurance training is again, just doing as much as you can and kind of building up that endurance. And so if they're tolerating 10 minutes of something today, and then hopefully you build up and add on to that as you continue to work through. Now, that being said, an infant and a child are a little bit different in the fact that from a tolerance standpoint, you're going to have good days and bad days, and you're going to have things that the kids love and the kids don't really necessarily love. So they may not like tummy time, but tummy time is important to work on head control and neck extension and trunk extension types of strength. And so thinking through ways to kind of incorporate that and make it as fun as possible. Again, use what you have and build as you go. So work with what you have and then build up on that. And again, a physical therapist that follows you in your multidisciplinary clinic, or that you may see on an outpatient basis on a regular basis, are going to help you understand how you progress exercise. You want back to playing in a variety of positions. So I mentioned tummy time. Tummy time is important. But you may need to do sitting on unlevel surfaces, or sitting and reaching, different kinds of things to kind of work on different aspects of strengthening. Movement for fun, again, incorporating fun, and then thinking about, as your child ages and gets older, starting to use a tricycle and a bicycle, and kind of finding ways to incorporate movement but keep it fun. Core strengthening is important. I've mentioned a couple of times neck extension and neck flexion weakness, and even in our pre-symptomatic treated infants and children, some of those impairments from a weakness standpoint are occurring more at the core. And so neck strength and core or trunk strength are really important, because that's where we kind of move from. And so focusing on that can even help with with greater ability to move overall. And then swimming is always an awesome option that basically takes the weight of the body away, but there's still resistance from the water. And so you get a really nice way to work on strengthening endurance, different things. And then and land-based needs to stay in the picture as well, because that's where we live. Okay. So I think in summary, Ann and I talked about this. We didn't want to do a ton of slides because we want to open this up to to your questions and make sure that we answer things that are important to you. But in summary, physical therapy and your multidisciplinary team really are extremely important for ongoing monitoring and care in your patients that are pre-symptomatic with SMA. So I think that's our last slide.
Looks like we have one question that has come in so far, and this is someone who has a daughter who was treated at 5.5 weeks old pre-symptomatically. She's asking, and this was commenting off of something that you were talking about. She said, I thought the idea of treating pre-symptomatically is that it acts like a cure because it's stopping the disease before progression starts. But it sounds like that you're saying symptoms might still show up.
Yeah, I can answer, and then Anne, please chime in. I think that as a physical therapist and in the medical community, we are trying to look for any potential impairments. And so from a standpoint of, do symptoms still show up? The answer is yes, possibly. And that's why we need to monitor. And it may be that we just see that there's a little bit of core weakness that we need to work on, or maybe a little bit of developmental delay that we need to work on. And again, I would just say that, and again, Anne, please jump in. But from a standpoint of the disease modifying therapies, we have to remember that there is the possibility that the child treated with whatever therapy is chosen may not respond exactly like some of the patients in the study did. Every individual is different, and we don't all respond the exact same way. And so it may be that therapy, while beneficial, isn't necessary. It's not necessarily curative in the fact that we still have to monitor for symptoms that may emerge either right away or later on in life.
And that is an important concept to remember, is that so if you have a normal SMN1 gene that is functioning, that gene is active throughout the development of the embryo, and there are different factors and other different modifying proteins and genes that are also active and work in concert with that SMN protein. And so while we classify a patient as pre-symptomatic and treat as early as possible, we know that that patient still has not received normal levels of that SMN protein and normal timing of receiving that protein throughout their entire development beforehand. So we know we aren't perfect. It's good, and it's so much better than it would have been otherwise. But we just know intellectually that we're not matching the normal physiology. So yes, the earlier you treat, the better, and perhaps the earlier you treat, maybe the closer we're getting to that normal physiology. But again, every patient is a little different. Every patient's going to respond a little differently. There are other modifier genes that are probably in play that we don't fully understand yet, that impact how patients respond to treatment. And so we're still learning. We're still gathering data. We haven't stopped learning yet. We haven't chalked this up to a cure and moved on. We're getting, we're a lot closer than we were, though. I hope that answers your question.
That's great. Thank you so much. And we just had one other question that came in that was asking, how old before babies can start swimming?
Oh, that's a great question. I'll let Leslie take that a little bit.
Yeah, I mean, you're talking to someone who, I'm not a professional swimmer, so as far as kind of developmentally when true swimming can start. But what I would answer to that is, I mean, I would get an infant in the water. As soon as you feel comfortable, as far as obviously supported and those kinds of things, because even if they're in some sort of, you know, floating device, they still have the capability to move their legs and their arms in the water and those kinds of things. And I know that we've used some different tools for some of our infants that have symptoms. They're basically devices that if a child or an infant has poor head control, they're inflatable devices that go around the neck to support the head so that their body can be immersed in the water, but their head is nice and control and stabilized above the water. And so that's an option to kind of use as well if you're ever concerned about just the head support or anything like that. So I don't know if there's a true age as far as when, I know there are infant classes, safety classes that get babies in the water to ensure that they learn how to float and those kinds of different things. Anne, do you have a better answer?
Yeah, I don't think that there's a minimal recommended age. I know hot tubs, you got to be careful with hot tubs.
Yeah.
Babies can get overheated in hot tubs very easily and not show you that they're struggling until there's a major problem with their cardiovascular system. So hot tubs, be careful. But a pool itself, I think in your arms, as soon as the umbilical cord is healing, if it's healed, if you want.
I think it comes down to your comfort level in the water. If you're a comfortable person in the water, or getting your infant in the water is perfectly fine. Yeah. And then I saw a comment here. Barbara mentioned a session about the pool that gave some great list of equipment, and I know that there have been some really good talks in the past about that as well. So look into that.
Wonderful. Thank you so much, Dr. Stratton and Leslie, for such a great and informative presentation today. We so appreciate your time and for being here with the SMA community. We thank everyone who joined in. There is a survey linked in the session page, and you will also be receiving it in a follow-up email. So please, we welcome any feedback that you have to share back with us. Once again, we are so incredibly thankful for the support from our sponsors for making the 2021 Virtual SMA Conference possible. Please join us for the third day of the virtual exhibit hall this afternoon from 3 to 5 Central Standard Time. If there is anything additional that we can do for you, please feel free to email us at familysupport@curesma.org. Have a great day, everyone, and thank you for joining us for the 2021 Virtual SMA Conference. Thank you.